Institute for MHRI, and I'm the director of the Women's Center for Positive Living, which is the regional referral center for prenatal care for women with HIV, as well as comprehensive preconception and gynecologic care. To give you a brief overview, I will be reviewing the HIV pandemic and current preventive strategies in cisgender women, and then I'll be sharing some PrEP research opportunities at MHRI, and I'll take your questions. Next slide. So I'll start with an overview of the HIV pandemic among cisgender women, as I mentioned, followed by current prevention strategies. And it's an especially exciting time to be speaking about this topic in light of World AIDS Day, but also in light of the associated recent change in the CDC guidelines around HIV prevention. Next slide. So to start with an international perspective, this heat map shows the proportional burden of HIV worldwide. In resource-rich settings, such as North America and Central and Western Europe, women comprise approximately 20 to 25% of new cases. However, in sub-Saharan Africa, which has the heaviest caseload of HIV, women, particularly young women, make up more than half of new cases. I saw a statistic recently that was like 57 to 68%, depending on the country. And women now comprise more than half of the 38 million individuals living with HIV worldwide, which translates to more than 19 million women living with HIV. The vast majority of women in both resource-rich and resource-limited settings acquire HIV through sexual transmission. And this growing prevalence of HIV among women worldwide is enabled by an estimated 8-fold higher sexual transmission efficacy from men to women, meaning that it's 8 times more likely for men to give HIV to women than in the reverse. But this inequity in HIV incidence is not due to biological differences between men and women. The HIV pandemic among women is driven by gender inequity and compounded by poverty. Since 2009, HIV/AIDS has been the leading cause of death among women of reproductive age around the world. And cisgender women bear the disproportionate burden of a preventable global pandemic. And HIV prevention in women remains critically underfunded and understudied relative to the pervasiveness and severity of the pandemic. Next slide. In the United States, the HIV epidemic is largely focused in the South and on the coasts. This slide depicts the prevalence of HIV among women in the US, and this heat map, although it's a couple years old, the distribution has actually changed very little. As you can see on the map on the left, parts of the South and New York City and Washington, DC have the highest rates of HIV. In terms of absolute numbers, you can see in the map on the right that there are also large pockets of women with HIV up and down the East and West coasts, as well as in the South. Next slide. Next, please. Over the past 2 decades, new HIV diagnoses, back one, are down overall among women in the US, down 25% among Black women, 20% among Latinas, and relatively stable among white women. This decrease is associated with an overall decrease in heterosexual transmission of HIV. And although this is really good news, racial disparities in HIV acquisition are still stark. 59% of new cases of HIV are among Black women and 16% among Latinas, compared to only 20% among white women. Next slide. Locally, as many of you are aware, Washington, DC is an epicenter of the HIV epidemic in the United States. Our prevalence changes from year to year and has gone down with gentrification, but hovers around 2%. And as you can see in this heat map, the majority of the cases are concentrated in wards 5, 6, 7, and 8. Next. And not surprisingly, women of color are disproportionately affected, representing 1 in 4 new cases of HIV in DC between 2015 to 2019. And the prevalence for women is over 8-fold higher than the national average. The DC Health reports that the prevalence among all women in DC is almost 1%, but is approximately double among women of reproductive age and even higher among women of color. Next. Nationally, Maryland ranks 5th in new adult HIV cases, below DC, Georgia, Louisiana, and Florida, and 9th highest in cumulative HIV cases, the majority of which are concentrated in the Baltimore City area. Women comprise almost 30% of new cases and a little over a third of all cases in the state of Maryland. Racial disparities are striking here as well. Black women represent 75% of new cases among women, bearing a disproportionate burden of the disease. Next slide. What makes these local statistics worse is that HIV is now highly preventable through both behavioral interventions, namely barrier contraception, such as condom use, and pre-exposure prophylaxis. Barrier contraception, specifically male condom use, is notably limited by issues of partner power discordance in addition to cost, stigma, and religious interdicts. Male condom use is implicitly dependent upon partner cooperation, highlighting the need for women-controlled HIV prevention options. The only FDA-approved pre-exposure prophylaxis drug, meaning a drug that you take before an exposure in order to prevent or decrease the risk of getting a disease, the only FDA-approved pre-exposure prophylaxis drug in cisgender women is a medication called tenofovir disoproxil fumarate emtricitabine, which I know is a mouthful. The non-generic name is Truvada, but I'll be referring to it as FTDF. So there's one other FDA-approved drug on the market for pre-exposure prophylaxis, however, not for women or not for cisgender women. Tenofovir alafenamide emtricitabine, or Descovy, which I'll refer to as FTAF compared to FTDF, is currently only approved in men who have sex with men and in transgender women who are having receptive anal intercourse. The Discover trial, which was a randomized control trial, and Dawn will talk about randomization later, for FTAF did not include cisgender women, and therefore cisgender women were not included in the FDA approval for the newest PrEP drug on the market. There are other drugs in the pipeline, such as the long-acting Cabotegravir injection, the Depivorine vaginal ring, some forms of Latrevir, among others, and we'll discuss some of these in upcoming slides. Unfortunately, women were largely excluded not only from this Discover trial, but also from much of the Sentinel research on PrEP that was done on PrEP acceptability and PrEP feasibility. And the result of this exclusion is that we lack data on how we can empower and enable women to make preventative health choices. We don't understand the PrEP cascade for women, meaning that we don't understand what motivates women to initiate PrEP and continue PrEP. And as a result, we don't know how to effectively market PrEP, and PrEP is grossly underutilized by women, leaving them at increased risk for unnecessary HIV exposure. So despite the evidence that women have increased biological susceptibility, higher rates of new infection worldwide, and younger age at time of infection, women continue to be left out of some pivotal PrEP clinical trials. And this lack of inclusion in PrEP trials leads to less prevention option for women and a critical lack of data on appropriate PrEP dosing and efficacy in women. And this is especially relevant in pregnancy. Next slide. So HIV prevention in pregnancy is critically important because of the increased risk of maternal HIV acquisition during this period. This is a very busy slide, but the point of this slide is that multiple studies demonstrate that there's a between 2 and 10-fold increase in HIV acquisition during pregnancy and postpartum. This increased incidence is attributed to both behavioral and biological changes during pregnancy. So on the behavioral side, without the incentive to avoid pregnancy, condom use is decreased during pregnancy, leaving women at increased behavioral risk for exposure to HIV transmission. On the biological side, during pregnancy and postpartum, there's a variety of factors, including changes in immunity, increased genital tract inflammation, trauma to the genital tract during delivery. And all of this is especially important as if mom does acquire HIV in this incident pregnancy, there's a 10-fold increase of mother-to-child transmission compared to if mom had acquired HIV in a previous pregnancy or outside of pregnancy. Next slide. So the standard dose of PrEP is recommended in pregnancy, the same dose that someone would take outside of pregnancy, but PrEP dosing has not been prospectively studied in pregnancy. So there's never been a study that was designed to really effectively look at the dosing and what the appropriate dose was. There have been multiple retrospective studies, and several observational pharmacokinetic or PK studies that look at the appropriateness of dosing, although looking backwards, of pregnant women on FTDF for PrEP or FTDF for HIV treatment demonstrated significantly lower levels of tenofovir, one of the key two drugs in that medication, in the blood in the second and third trimester. And this decrease is associated with known pregnancy-associated changes. So specifically, there's an increase in the overall blood volume. So the PrEP is more dilute, and also increased excretion by the kidneys. So the PrEP drug is flushed out more quickly. And this is particularly concerning in the case of PrEP in that it may no longer be as protective. And the reason for concern in this case particularly is that we know that outside of pregnancy, near perfect adherence is required for non-pregnant women to achieve the same high efficacy, that greater than 90% efficacy that's been demonstrated in men who have sex with men. And this is due to differences in the way the PrEP drug concentrates and penetrates the cervical vaginal tissue versus the anus and the rectum. So if near perfect adherence is required outside of pregnancy, given all these known changes in pregnancy, there's concern that the standard dose may no longer be as protective. So we don't know that PrEP is less effective in pregnancy. And the reason we don't know is because it has never really been prospectively studied. But there aren't reports on that either yet. But the take-home message of this slide isn't that we shouldn't give PrEP to pregnant women or that we shouldn't do everything we can to prevent HIV in pregnancy. It's that we need to include all women, especially pregnant women, in research so that we can give them the best possible and most evidence-based prevention options and treatment options for all medical conditions, including HIV. Next slide, please. So moving on to PrEP drugs, we will be going over what's currently available and what's in the pipeline. I want to quickly review some of the new CDC changes. There used to be a long list, laundry list of exposures of HIV risk factors that the CDC listed as eligibility criteria, such as having a partner that was living with HIV, a recent bacterial sexually transmitted infection, such as chlamydia or gonorrhea, and IV drug use. And these still exist, but the new PrEP recommendations, the new PrEP guidelines recommend that medical providers speak with all sexually active adults and adolescents on PrEP, not just people at high risk, in order to increase awareness of PrEP and decrease the stigma about PrEP. So the fact of the matter is that places in DC with really high rates of HIV, like I just showed, sexually active adults are at increased risk of HIV exposure because of this high prevalence of HIV, not because sexual practices are different in DC than they are in, say, Idaho or Montana. And it's important to think about it in that context. Further, the CDC is placing less emphasis on these eligibility criteria and acknowledging that not all patients are going to disclose their possible HIV exposures to a doctor or a nurse, especially if they've just met. And therefore, there's a new recommendation that if a patient asks for PrEP, given how low risk the medication is, that he or she be given PrEP, prescribed PrEP, regardless of whether or not there are documented risk factors. And that's a new and I think really important change and paradigm shift for how we look at prevention and how we end the HIV epidemic effectively. Next slide. So I talked a little bit about FTDF before. It is a daily oral medication. As I also mentioned, near perfect adherence is required in non-pregnant women to achieve the same greater than 90% efficacy that has been demonstrated in men who have sex with men. And again, this is secondary to a 10-fold concentration difference in the cervical vaginal tissue compared to the colorectal tissue. Taken daily, though, it is highly effective and decreases HIV transmission by 92% in heterosexual couples. And this was really the first effective drug that we have had to prevent HIV, which has been really groundbreaking. It is a very safe medication, and we know a lot about it. Some patients do complain of a startup syndrome, which includes some gassiness, some nausea, mild headache, but most symptoms do resolve within the first 30 days. And there's a documented, I can't talk right now, sweetie, I'm sorry. There's a documented bone mineral density decrease that is associated with FTDF. Excuse me. Sorry about that. That is associated with a 1 to 2% decrease in bone mineral density. So like osteoporosis, but this has been less of an issue in our HIV negative population. And we know that it decreases returns back to baseline after discontinuation. And there's been no long-term impact in, for example, adolescents whose bones are still developing. Lastly, there's a theoretical concern for decreased kidney function, but that really, again, hasn't been very significant at all. Next slide. The next medication I want to talk about, the next PrEP drug I want to talk about is tenofovir alafenamide, or TAF, which again is a daily oral medication which is FDA approved for pre-exposure prophylaxis, but only in men who have sex with men and transgender women who have receptive anal intercourse. It is approved in all men and women for treatment of HIV, just not for prevention. It's similar to FTDF in that both are prodrugs of tenofovir, meaning that they're activated into their active form after you ingest them. But one of the main differences is this has less effect on both bone and kidney, which is great. It has been studied extensively as part of HIV therapy and treatment for men and women, but just not, there's still limited data on safety and efficacy as pre-exposure prophylaxis in cisgender women. But there are studies that are ongoing, and we're hopeful in the next couple of years that it'll be approved for women, for cisgender women as well. Next slide. The next drug I want to talk about is the Depivorine Ring, which is a little bit complicated to discuss, but we're going to get into it. It's an intravaginal ring that patients insert monthly. It has minimal systemic absorption, meaning that it really just absorbs in the tissue in the vagina, and it offers local protection as a result, similar to a microbicide, if anyone's familiar. And it offers women who struggle with taking a pill every day or with swallowing pills, it offers them an alternative. It's worth noting here that in the original pill PrEP trials, the oral PrEP trials of FTDF, in women, they actually weren't found to be effective. And the reason why is because women didn't like taking a pill every day for something that was prevention. You can often convince people to take a pill for a known health problem like diabetes, or when people know that they, have high blood pressure, but to prevent something, it's often hard to convince people to take a medication every day. And so this ring offers a monthly alternative to taking a pill every day, and offers the potential for protection against HIV compared to doing nothing at all, given the differences in adherence. So there were two trials. One was the Aspire trial and one was the Ring trial, and both were compared to placebo, meaning a ring that had nothing in it effectively. And the Depivorine Ring was found to reduce HIV by between 27 to 37%, depending on the trial, and depending on the subgroup analysis, which is it's not fantastic, but it's a lot better than nothing. And it's really important to recognize that it is an alternative for women that really just can't take an oral regimen on a daily basis, and it is very safe. And it's just really important that we find more accessible and acceptable options to women for HIV prevention as part of ending the HIV epidemic. Next slide. The long-acting Cabotegravir injection is likely the next drug to be approved by the FDA for PrEP, hopefully for both men and women. It is a every 2-month injection. It is amazingly effective compared to oral PrEP, not compared to placebo. And a lot of this, again, probably has to do with adherence, in that if you get your injection, you don't have to remember to take a pill every day. The injection is every 2 months. There are some concerns largely around implementation of all the visits for injections, and also how to safely transition individuals who are on CAB off of CAB once they decide that they no longer want to receive injections. It is currently FDA approved only for treatment, but it's anticipated to be approved for PrEP as soon as February. Next slide. Latrevir is currently in studies. We actually have 2 trials going on at MHRI. There is a monthly pill and a yearly implant, which are currently in phase 3 and 2 respectively. Next slide. So we currently have, I want to say, about 6 PrEP studies currently open. I'm going to mention 3 of them, but if anyone is interested in participating in PrEP research, please reach out, and the contact information for my research team is on one of the subsequent slides. If you don't see a study here, or I don't mention a study here that fits your demographic, we may have other opportunities, or we're happy to take your information for future trials that we may be opening. Next slide. So we have 2 studies on Latrevir. One is a study specifically in women of a monthly pill. It's a randomized control trial of FTDF compared to a monthly Latrevir pill. And there's a second slide that will be for an implant in both men and women in healthy controls. Both of these studies are currently on temporary hold to evaluate a potential safety signal, but we anticipate that both will be open to enrollment again in the next couple of months. Next slide. You can actually skip this one. Next slide. And this next study is not a drug study. It is about PrEP, but the objective is actually to talk to women and better understand what they want from PrEP and in what form. How often do they want to be taking it? Do they want a pill, an implant, a shot, and what they want PrEP treatment and care to look like. Next slide. So Trisha Moriarty and Trinessa Hansen are my amazing research team. Trisha is out in the next week and a half, but she will be checking email once she gets back, and Trinessa is on email constantly, and you are more than welcome to email one or both of them, or give their office a call and leave a message. Those are their work cell phone numbers, which you're welcome to use as well. And we welcome your potential future participation in the current trials we have going on or in other future trials. Next slide. So that's it. Thank you so much for your time and attention, and I welcome any questions you might have.
Okay, great. Thank you so much, Rachel. That was really important and inspiring, especially, the need to study this in cisgender women. I see that we do have some time for questions now, so I'll look at the chat and see if we have anything. What you can see also in the chat is Almina putting in some of these links and the phone numbers, so you could copy this directly. We do have a small group, so if anyone wants to ask a question and unmute yourself, feel free to do that as well. If that's
Almina, you're also welcome to put my email in the chat in case anyone that's watching this on social media or on YouTube has a question about the presentation itself.
Sure, of course. I'll pop in Dr. Scott's email in the chat as well.
But you might want to specify it specifically for content questions, not for, well, I can forward anything that comes to me. It's no problem. I'm a compulsive email checker. What am I talking about?
Sure.
I have a couple of questions.
Sure.
Does anyone else have a question right now? I don't see any. So I have a couple of questions, and
one at a time.
So are there any other ways to take PrEP right now other than taking it daily?
No, not for women. Not for women. Right. There are for men.
Exactly.
So so this talk was obviously geared towards cisgender women. For both transgender women and for men who have sex with men, there's what they're called PrEP on demand, which is a 2-1-1 where you take 2 PrEP pills before exposure and a pill a day for the 2 days to follow. And so it's a much easier regimen and that you aren't required to take it for quite as long. For women, because of differences in tissue penetration, the way the drug concentrates in the tissue, we know that women need to be on the drug for 3 weeks leading up to the exposure, and then for 30 days after an exposure. So unfortunately, the way the current drugs work right now, they just don't work quite as well for cervical vaginal tissue. What about, sorry,
yeah,
I'm
go
just saying a
ahead.
question.
And I
What
see-
about for trans men? They only, correct. So actually there is, I don't want to say correct. I want to say the assumption is that it's only a daily option. We unfortunately really don't have the data. Let me back up. We have the best data in white cisgender men who have sex with men. We have some data in transgender women who were included in those same trials, but a lot of the transgender women that were included in those trials were not necessarily on gender affirming hormone therapy. So it's unclear if PrEP is quite as effective and if there's any issues for transgender women who are on full dose estrogen therapy, or for transgender women who are having neovaginal receptive sex, meaning transgender women who have transitioned and are having sex in the vagina. For trans men, I've seen next to no literature. My presumption is that it would depend on the kind of intercourse a trans man is having, but I would assume that numbers would, the statistics would be pretty similar to cisgender women, but unfortunately, there has not been a push from the pharmaceutical industry to study PrEP in transgender men. And so we just unfortunately don't have that data. So it's mostly extrapolation and expert opinion.
Do we have other questions from the group? I have another question. I know in a lot of the original studies, most of these studies were all based on using PrEP, but also using condoms, right, in the studies. And is this the case for the future studies as well? Is that going to change at all?
So the original studies, the earlier studies were all PrEP versus placebo.
Right.
And they handed out condoms. We know that condoms are a nice thought, and we know that condoms do work reasonably well when used. We also know that realistically, most couples don't use condoms and don't always use condoms the way condoms are meant to be used. Doing a placebo trial is no longer ethically acceptable, given that we know how well FTDF works. So you may have heard me mention the Cabotegravir study that just finished. It's one of the HPTN trials. They did it in both men, and then they also did it in cisgender women. And both of those trials were compared to FTDF as the gold standard, as opposed to placebo, because it's no longer ethically acceptable to compare compared to nothing in condoms, given that we know we have an effective alternative.
Right.
But yeah. Condoms are always great, because even the most effective PrEP is only going to protect against HIV, not against gonorrhea or chlamydia or syphilis or the whole host of bugs that are out there. But realistically, we know that most couples and most people don't like using condoms, and we have to meet people where they're at and make sure that people are doing what they're doing in the safest way possible. But not shame people for the choices that they're making.
The studies are still approved, though, recommending condom use.
Yeah, I think the same way clinically we recommend condom use, studies also recommend condom use, and a lot of them will pass out condoms, but it's no longer compared to condom use alone, and there's no condom mandate. The Partners Demonstration Project and the Partners PrEP studies specifically looked at PrEP in serodiscordant couples, so both heterosexual and gay couples who where one partner had HIV and the other partner did not. And there's a lot of data to show how effective PrEP is, but also how effective having a partner with a suppressed viral load also is, which is referred to as untransmittable undetectable is untransmittable, or U equals U. So there's been a lot of changes and a lot of really positive changes in the way we think about HIV prevention, and the way we think about how to study HIV prevention.
I have a question. Thank you, Rachel, for the presentation. How about the medication adherence, especially for prevention? So I know mostly these populations might be difficult to work with. And then they may get on the medication, but they may not stay on the medication. So do the drugs work if patients, for instance, instead of taking it every day, take it every other day, or
So in men, it works. In women, it doesn't work as well because the tissue levels don't get quite as high. It's still better than nothing, but it's not as effective. And that's why really it's not, I'm a gynecologist, right? So it all comes, I bring everything back to gynecology. It's not that different than birth control pills. People are bad at taking a pill every day. And women, for the most part, are bad at taking a birth control pill every day. That's why we invented IUDs and the Nexplanon implant and the Nuva vaginal ring, and the Depo shot. We have tons of options of contraception, and PrEP is only now catching up to that by thinking outside the box and not just offering people a pill, but offering them things that work better with their lifestyle. It's really challenging, even for those of us that are hyper organized, to do anything at the same time every day. And so I can't blame people for not taking their pills perfectly. I was on antibiotics a couple of months ago. I had to set an alarm or I couldn't remember. So it's really challenging, and it's even more challenging, as I mentioned, when it's for something you're not feeling or noticing. I took my antibiotics for my sinus infection, but the second I started to feel better, I had to set the cell phone alarm or I was going to forget to do it. And it's the same thing with anything preventative. If it's not in your face and bothering you, it's human nature to kind of push it away and, get busy with, your kids and your job and your everything else. So, yes, I think adherence is going to continue to be a big issue with anything that's a pill. That said, I do believe in choice, and I believe in I don't think we should throw pills out the door. I think having pills for people that want to take pills and are good at taking pills is great. And I think especially in situations like pregnancy, where we want something that is potentially shorter acting, granted, we do need to look at dosing, but where you might want something that's shorter acting, you might not want to be on a 2-month pill, a 2-month injection while you're in pregnancy, especially when you don't know what that looks like. But I think giving women and giving all people the full gamut of prevention options and seeing what works best with their lifestyle and their personal desires is, I think, the way to go. And it's the direction that things are moving in.
Thank you.
Okay, if we don't have any questions in the box, I'll move on to the next part, but please continue to put your questions in the chat box. It could be for Dr. Scott's talk, my talk, or any of the above. And we should
Thank you so much for your questions. Thank you.
We should have time at the end as well. Okay, so I want to bring this important discussion to talk about randomization in clinical research. And Dr. Scott has mentioned this several times in her talk, and we'll discuss it. But on the right-hand side, you can see is basically a study that's looking at some intervention in people who are looking for work, and some people get the intervention and some people get the control. So basically the randomization, and a lot of you already know this, is like the flip of a coin, and it's done by computer, and it assigns research participants into one group or the other group, so that it's done by chance, and so that that different groups are going to receive the different treatments. Now, during the trial, or at the end of the trial, the researchers are going to compare the groups, and they're going to look at side effects, and they're going to look at safety events, they're going to look at treatment efficacy or effectiveness, and then they're going to be able to compare this because it's going to be different randomized groups. And I'll get into that a little bit in a second. So there's usually a control group, and this control group is either receiving a standard treatment or it could be receiving a placebo, as Rachel has mentioned already. And then it's comparing it to either a new treatment, a new intervention. And it could be several arms also to these, to these different groups. But the main importance is to prevent any bias in the study. And especially if a study can be influenced by some other action that a participant or other outside factors, even a doctor putting them on some medication, that are not specifically related to the study drug or intervention, because then that could affect the outcome and then the interpretation of the study results, resulting in a significant error. And, that's going to affect how we use the medications or the interventions later on. So this cartoon on the left is just showing, basically, after consent, we take different information and we enter it into a computer, and then the participants are selected by a randomizing program. And this is by chance, not by choice. And neither them, their physicians, the study investigators, the coordinators, they usually cannot, decide which arm it's going to be on. And we've spoken about blinded trials before, but often they're randomized blinded studies, which is what, like even Rachel mentioned in some of the PrEP studies. So this is, there are going to be certain characteristics that are decided before the study starts, during the study design, that the people are going to be sort of, similar in the two groups, like maybe age or some other treatment, health conditions or something like that. And so those are going to be similar between the groups, and then they're going to randomize just by chance into the treatment or the not treatment. So this way we know that if a difference is found between the groups, that we know it's real and we know it's valid from the treatment or intervention itself, but not from other health conditions, weight or blood pressure or something else. So these, we want to make sure that we can't influence the outcomes of the study. So an additional, benefit, so let me just move on, I think. Yeah. So an additional benefit of the study, and this is important because we really want to make sure that there is fair treatment of all participants. We use a term equipoise in several different ways, but we want to make sure that it's equitable to all participants and that all volunteers get to have the same opportunities. So like in the cartoon on right, this is probably not an equitable randomization because 50% got shorter vacations. But it's, we want to make sure that everyone has the same chance in the study. And, the thing is that some studies can't really even use randomization equitably. Like if there are two drugs that are already approved and on the market that people can't come off the medications and you're comparing them, then you're not going to randomize. So randomization is not always used in every study. Like for instance, let's say now we want to look at COVID vaccinations and compare the different vaccines to the other, but not necessarily giving them the vaccine. Well, you can't even change that. You can't randomize because people had that, but you can compare them. There are so many different ways of randomizing, and I'm not going to go into the different ways at all. So I just want to bring this back to PrEP. And really most of the trials in PrEP have been randomized trials. The study that Dr. Scott was speaking about, the last study, I don't believe is going to be a randomized study because that's going to be asking people about their perceptions and about going on to PrEP. But, in these clinical trials where we're looking at different medications, people have been randomized. And so like in the initial studies, they were done against placebo. So this is the FTDF study, the Truvada study. And this is what Rachel was talking about in the initial men having sex with men or transgender women, sorry. And then and that was to placebo because at the time you were able to randomize to placebo. And then this next study was the partner study, which also Rachel mentioned, and this was in discordant couples, and they looked at 3 different arms, one of the arms still being placebo. But in the Latrevir study, which Rachel was mentioning, we can't use the placebo anymore. So we're going to randomize still, but we're not going to randomize to a placebo controlled. And I think I just want people to be at least clear on that, on that. And we want to make sure that, all of these have the same safety profile. So that's really all I want to mention about the randomization itself. Now, I did want to mention that we've had, since the beginning of the COVID pandemic, we started with the community engagement group at GUTS, and they really drove this process of putting a lot of clinical research concepts into simplified ways for the community. And these are all available on this site right here. And I think Almina's probably putting it into the chat right now. And we took all of these. I think this is the last one that we used in this series. So we did speak about other things like, about the ethics of randomization, the ethics of consenting people, placebo trials. So we did speak a lot about that. But I want, people to know that these other topics were also on this website. So I think I could take any questions about randomization, or we could look if there are any other questions for Dr. Scott right now. And if not, then I'll have Wendy start closing out the discussion. I was a little nervous when I saw one of our investigator statisticians come on when I was giving this randomization talk, but I'm glad she has no questions for me. I tried to keep it as simple so I could understand it.
Yeah, and just so that I mentioned it at the beginning of the presentation, this presentation will be available on our GUTS in the community website, as well as YouTube and our Facebook channel. So feel free to share it with anyone who you may think is interested in learning more about the topic. Both of the presentations are extremely educational. So thank you so much, Dr. Scott and Dr. Fishbein. And again, we're still going to give a few minutes for anyone. You can type your question in the chat box, or feel free to unmute yourself and ask the question directly.
I guess, Wendy, we could have you move on, and if people have questions.
Yeah, feel free to ask any questions. Like the next slide that we just have, it's just other resources that are available for our community. Anyone who's interested in learning more about like research studies or might be interested in participating, researchmatch.org is a great way to go about it. You can just go on the website and type in any keyword about any particular study that you might be interested in. And then you can sign up as a participant, and also our investigators use that. We have our Partner for Research website, where we also share a lot of information just on all these different topics. We share information about different studies as well. So that's another great resource for you. And we also have a participant advisory board where we constantly recruit new members. So if you're interested, we are adding the link on the chat. So if you're interested in participating and create, and represent the community, share your ideas and goals, and help with recruiting, implementation, evaluation of various research studies, this is a great opportunity for you.
I wanted to say in terms of, I'm sorry for cutting.
Yeah, go for it. Yeah.
I work with Ed from the Department of Influencers at MI2. I don't know if you've heard of him before, but today I talked with him about something else. And then he said he often does consulting for clinical trials to increase participation rates. So especially for difficult to recruit studies, it may be a good idea to keep that resource in mind also. So Rachel,
Great.
you may want to talk to him if he may be able to help for, I don't know, to write up stuff to be more
Sure,
appealing.
we're always open to new ideas. Thank
Okay.
you.
Sure.
And we'll reach out to you, Mireille, to find out more as well for our recruitment group.
Yeah, absolutely.
Thank you.
Yeah, thank you so much. And then again, like we still have a few minutes, but just to wrap it up, we have time to give credit where credit is due. Our GATS in the virtual community core team is comprised by Dr. Dawn Fishbein, who's our medical director, Dr. Finney Richardson, who's our participant advisory board director, and I think she's also on the call tonight. One of our managers, who's Allison Moses, myself, Wendy Enriquez, Almina, who's our research assistant. We have other members that are not with us tonight on the call, but there's Tonya Bishop, Ilan Donella. We have Florencia Gonzalez as well, Carla Williams, and many other individuals who form a part of GATS that we're very happy to have on our team. And if you have any other questions that you were not able to ask right now, or you want to ask later, you can always send us an email, and this is where you can also find frequently asked questions that we have already answered. So we'll put that on that link on the chat as well.
Thank you very much.
Yeah, thank you, everyone. We will also send a survey to our presenters, but also all of our participants. And we really do take your opinion when it comes to creating these presentations and selecting the topics. So please please take our survey, and then we'll be looking forward to that, to receiving that feedback. And so typically we put our next date for our next topic here, but that's still to be determined. But just as a reminder, it does happen the fourth Tuesday of the month. But again, if you visit our website, you will be seeing there once we have our topic and the date there. So looking forward to have you all joining us for our next topic in January and all of the upcoming months.
Thank you.
All right, well, since there were no other questions, this culminates our presentation tonight. Thank you so much, Dr. Scott and Dr. Fishbein again, and looking forward to staying connected.
Thank you so much.
Thank you, everybody.
Thanks so much. Good night.